Atrial arrhythmias. In this section, we will be discussing rhythms that arise from the atria. In this section, you will learn about atrial rhythms, including wandering atrial pacemaker, or WAP, premature atrial contraction, or PAC, both the conducted and non-conducted forms, atrial tachycardia, also known as paroxysmal atrial tachycardia, or PAT, or SVT, or supraventricular tachycardia, atrial flutter, and atrial fibrillation. Atrial arrhythmias are electrical impulses that originate from ectopic sites in the atria. Because they're going to be ectopic in origin, one of the major characteristics of atrial rhythms will be a different P-wave morphology. P-waves will be different in appearance, or perhaps they might be different in shape, different in size as well. Wandering atrial pacemaker. In a wandering atrial pacemaker, the impulses are coming from different parts of the atria. Sometimes the sinus node discharges, creating a P wave, but other times there are ectopic sites in the atria that also produce a P wave, resulting in different configurations of the P wave. Now, if this were the atria, that means to say that sometimes the sinus node fires, it creates a normal P wave, but sometimes other parts of the atria will also create electrical impulses, and therefore there's going to be a changing pattern of the P waves. If there are 3 or more different configurations of a P wave, this will suggest that there is a wandering atrial pacemaker. Let's go ahead and analyze this ECG strip, which demonstrates wandering atrial pacemaker. First, let's analyze the rhythm, and we're going to take a look with our caliper, and it looks like it is essentially regular. Okay, it's regular. And now we determine the rate. The rate is 1, 2, 3, 4, 5, 6, 7. It's 70. P waves. When we look at the P waves, we notice that the first P wave and the second P wave are inverted, and the third P wave is upright, but it's a little bit different. And again, it is different throughout. So there are 3 different configurations of a P wave, and therefore it is abnormal. The PR interval. Let's measure the PR interval. The PR interval might be consistent or it might be inconsistent in some instances in cases of a WAP. So let's take a look at it, and let's move this, and it looks like it's going to be consistent, and it is, let's see, 4 boxes around 0.16 seconds. Next, we're going to measure the QRS complex, and the QRS complex is going to be this measurement right here, a little bit more right there. And so let's see, it's around 2 boxes, and so it's around 0.08 seconds. Because of the changing morphology or the appearance of the P wave, we therefore can conclude that this is a WAP, or a wandering atrial pacemaker. Wandering atrial pacemaker is not clinically significant, and it usually will not cause problems with the patient. However, if it accompanies a slow rhythm, then the treatment would be the same as that of bradycardia. WAP may also be associated with a fast rhythm. When this happens, then it is aptly identified as a multifocal atrial tachycardia. The word premature suggests that the beat is early. So this underscores the characteristic of a premature atrial contraction. 1, there is an early P wave. And number 2, this early P wave must be different in morphology or in characteristics as the other P waves. Let's examine this particular ECG strip to illustrate the premature atrial contraction. In this ECG strip, if we notice that the rhythm is irregular, the heart rate is is 70 per minute. And I need to underscore this particular part right over here. As you could see, the rhythm was regular, and there is this beat that came in early. An early beat is always identified as a premature beat. And this premature beat, because of the fact that it has a P wave, is going to be identified as a PAC. Notice that in addition to it being early, the P wave looks different from the rest of the P wave. This results whenever you have a premature beat, you will always have a pause following this premature beat. And we will see these in other kinds of premature beats as well. Further analyzing this strip, we notice that the P waves are present except for this one P wave that is different right over here. And of course, the PR intervals are going to be normal. It appears like it's around 0.20 seconds. These are all normal. So this is what is known as a PAC. Because a premature beat interrupts an established rhythm, therefore we always have to identify the underlying rhythm that is going to be present. Remember now that a premature atrial contraction or a premature beat just interrupts a regular rhythm. And therefore in this particular instance, we identify that the underlying rhythm is a sinus rhythm with one PC. Non-conducted PAC, also known as a block PAC. In this strip, we see a P wave that appears to be early. Where the arrow is pointing is a P wave that is early, but it doesn't have a QRS complex. The fact that the P wave is early is an indication that this is a premature beat. And because the premature beat is a P wave, we would call this a premature atrial contraction. However, the difference with the PAC that we had mentioned earlier, which was conducted, is that this premature P wave is not followed by a QRS complex. Anytime that we have a P wave without a QRS complex, this indicates that the impulse did not or was not able to be conducted all the way to the ventricles. And the reason why this might be is because the ventricles might have been still in its refractory period and therefore was unable to transmit the electrical impulses to the bundle of His, to the bundle branches, and to the Purkinje fibers. Thus, there is an absence of a QRS complex. So, when a premature beat, which is a P wave, is noticed, but there is no corresponding or partner QRS, then this is exactly what I meant by the fact that it was not transmitted all the way to the ventricles. We call this a non-conducted PAC. A non-conducted PAC may be confused with a sinus pause, but there's a difference. Let's take a look at the difference between a conducted PAC and a non-conducted PAC. If you see in this illustration right here, notice now that in this particular pause, there is something that is different, however, and that is the appearance of a P wave. This P wave indicates that this is going to be coming from the atria. If we were to look at the regularity of the P waves, notice now that the basic rhythm is going to be this. From one P wave to another P wave is going to be normal or regular rhythm. But right over here, the P wave should be in this area. But as we could see, the P wave appeared early. So, inasmuch as it's an early P wave, we call this a premature atrial contraction. And because the PAC is not followed by a QRS complex, then we call it a non-conducted PAC. A non-conducted PAC is also called a block PAC, which is the other term. There are some situations wherein the premature beat occurs very early that it is going to be covered by the T wave. So let's take a look the one that has the arrow in this particular strip. What's significant in this ECG is we see that there is a pause, and within the pause, we see that the T wave is different from the rest of the T wave. So I'm pointing at the T wave right over here. Compare that now to the previous T waves, which are shaped like this. Now, the reason why this T wave is a little bit different from the rest of the T waves is because of the fact that there is a P wave underneath this T wave, causing the contour of the T wave to change. So this is still, again, an evidence there that there is a premature beat, and this premature beat is a PAC. We assume that there is a P wave based on the different T wave configuration within that pause, as illustrated or pointed by the arrow. Non-conducted PACs will have the same treatment or implications as the conducted PAC. PACs may be caused by stress or ingestion of stimulants such as alcohol or caffeine or drugs, hypoxia, electrolyte imbalances, myocardial ischemia, or atrial enlargement, and some drugs which might cause premature atrial contractions. Supraventricular tachycardia, paroxysmal atrial tachycardia, or narrow complex tachycardia is a rhythm that originates from the atria. There is an ectopic site in the atria that repetitively fires rapidly, creating this particular rhythm. But let's take a look at the terms that are used to describe this rhythm. First, paroxysmal atrial tachycardia, or PAT. The word paroxysm suggests that the rhythm is sudden in its onset and sudden in its termination. And that is the reason why it is termed paroxysmal atrial tachycardia, because of the sudden onset and the sudden termination of this rhythm. It is also known as supraventricular tachycardia. So let's take a look at that term, supraventricular. Now, the word supraventricular suggests that the rhythm originates from above the ventricles. And this has a very, very important implication. So, if this were the ventricle, what is above the ventricles? Well, above the ventricles are the following structures: the AV node, the atria, as well as the sinus node. The word supraventricular suggests that this rhythm originates from above the ventricles. It could therefore come from the AV node as well as the atria and also the sinus node. But we all know that the sinus node has a potential rate or an automaticity rate of only 60 to 100. And if there is an enhanced automaticity, that the sinus node can develop tachycardia up to a rate of 160. So any rate that is going to be above 160 will be supraventricular in origin and is most likely going to come from an area in the atrium. The other term that describes this particular rhythm is narrow complex tachycardia. The narrow complex refers to the QRS complex. And the reason why this term is used is because it is assumed that the travel of electricity goes through the bundle of His and and the bundle branches in a normal fashion. So if this were the AV node, and this is the bundle of His, and the bundle branches right over here, when an impulse originates from the atria and travels to the AV node, to the bundle of His, and to the bundle branches normally, it should result in a narrow QRS complex. Patients with supraventricular tachycardia will usually feel the fluttering in their chest. The patient should be observed for tolerance of the rhythm, and the treatment for supraventricular tachycardia has the goal of eliminating the cause, slowing down the rate, and converting it to normal sinus rhythm. The approach for the management of patients with supraventricular tachycardia, or PAT, includes sedation as well as vagal maneuvers, and there are several ways in which we could activate the vagus nerve in order to act. Listed in here are the various vagal maneuvers that could be tried. As far as drugs are concerned, adenosine is a specific drug for the management of patients with supraventricular tachycardia. If that fails, other drugs could be used, such as calcium channel blockers. An example of that is diltiazem or cardizem, or perhaps beta blockers. If the patient doesn't tolerate the rhythm, then cardioversion might be in order. And for cardioversion, the patient is going to be sedated, and then of course the electrical energy of synchronized electrical cardioversion will be employed. Here's an example of an ECG strip illustrating paroxysmal atrial tachycardia, or SVT. As we can see, the rhythm is regular. So let's go ahead and take our caliper over here and determine its rhythm. And the rhythm is regular. All right, let's go to the rate. The rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So it's 170 beats per minute. P waves. P waves are not going to be identifiable in cases of supraventricular tachycardia, or PAT, because of the fast rate. Due to the fast rate, what's going to happen is that the waves are going to be compressed, and therefore it's not going to be easy to identify the P wave. The PR interval therefore could not be measured. Let's go ahead and measure the QRS complex. So let's go ahead and zoom this so that you will be able to identify the QRS complex. And we're now going to measure it. And if we measure it, it's almost this, and it is around 2 boxes. So it's 0.08 seconds. The fast rate, the narrow QRS complex, suggests that this is supraventricular in origin, and this is therefore supraventricular tachycardia. Here's an example of a SVT on the monitor. The next rhythm is atrial flutter. Atrial flutter originates from an ectopic pacemaker in the atria, and it creates a classic wavy P wave which looks like a sawtooth. This is an easily recognizable rhythm because of the characteristic sawtooth pattern. The sawtooth pattern are referred to as flutter waves. They represent atrial activity at a very rapid rate. This rapid rate is usually around 250 to around 400 beats per minute, and therefore creates a wavy baseline, which is characteristic of this particular rhythm. The ECG characteristics of atrial flutter are: the rhythm is regular or irregular, the atrial rate is fast, usually around 250 to 400 beats per minute, but the ventricular rate will vary, and the P waves will have a sawtooth appearance. PR interval is not measurable, and the QRS complex will be normal. Atrial flutter is an abnormal finding. The causes of atrial flutter might be related to cardiac abnormalities, especially the mitral and the tricuspid valves. It is also seen in patients who have hyperthyroidism as well as pulmonary emboli and COPD. Certain substances may also contribute to atrial flutter. The implications for atrial flutter will be discussed along with atrial fibrillation because they actually share the same. This will include a potential for decreasing the cardiac output because of the loss of the contribution of atrial contraction to ventricular preload. Let us analyze this ECG strip. The rhythm appears to be regular, so let's take a look at it. It is regular. The rate is 1, 2, 3, 4, 5, 6, 60 P waves. We see this characteristic flutter waves. There are many of them, which looks like a sawtooth. PR interval cannot be measured. And the QRS complex, let's go ahead and measure that. And I'm going to zoom it so that we could measure it well. And it appears like it's 2 boxes or 0.08 seconds. This rhythm demonstrates that there are more P waves than QRS complexes, and this is because the AV node is doing its job of blocking excessive impulses that are going into the ventricles. That is the reason why we have more P waves, known as flutter waves, than the QRS complex. This is atrial flutter. Atrial fibrillation. In atrial fibrillation, there are numerous ectopic sites in the atria that are firing repetitively. This causes the atria to quiver and lose its contracting ability. This results in a very irregular rhythm. In fact, atrial fibrillation is the most irregular rhythm in electrocardiography, and it usually is referred to as an irregularly irregular rhythm. Let's take a look at an example of an atrial fibrillation in an ECG. The rhythm is irregular. As you could see, the very irregular pattern of this ECG strip. The rate is slow. It's 40 per minute. P waves are non-identifiable. This is the hallmark of atrial fibrillation. They're usually unidentifiable P wave. If you take a look at the strip and you're wondering where the P wave is, it's most likely that there is none. And this is a very characteristic finding in patients with atrial fibrillation. The PR interval therefore cannot be measured. The QRS complex will be normal. Let's try to measure. And it is around 2.5 boxes, so that's 0.10 seconds. The ECG characteristics of atrial fibrillation are: the rhythm is irregularly irregular. Rate, it would vary. P waves, they're non-identifiable, and there is a wavy baseline. PR interval is unmeasurable, and QRS complex is normal. When describing atrial fib, the following should be followed. Rates that are less than 60 would be atrial fibrillation with slow ventricular response. Rates between 60 to 100 is controlled atrial fibrillation. Atrial fib with ventricular rates above 100 is described as uncontrolled atrial fibrillation. Implications of atrial flutter and atrial fibrillation. In both these rhythms, atrial flutter and atrial fibrillation, the potential for a fast heart rate is going to be high. And we all know that an increase in heart rate could potentially increase the demand for cardiac output. And because of the fact that the atrial kick is lost, meaning to say that the atrial contraction is going to be lost, it can further reduce cardiac output. Atrial fibrillation is a very common rhythm. Atrial fibrillation is actually one of the most common rhythms seen next to normal sinus rhythm. One of the most significant complications associated with atrial fibrillation and atrial flutter is the potential for the development of blood clots. Blood clots form as a result of the quivering of the atria, and the potential for these blood clots to travel outside of the heart is going to be very high. In fact, the majority of embolic strokes are caused by blood clots resulting from atrial fibrillation. The goals for treatment of atrial flutter and atrial fibrillation includes controlling the ventricular rate, anticoagulation to prevent thromboembolic phenomenon, and to restore the rhythm to sinus rhythm. Drug therapy usually is going to include the use of calcium channel blockers, in particular diltiazem, or as an alternative beta blockers. If the rhythm has been going on for less than 48 hours, then it is assumed that it is safe to convert using amiodarone or cardioversion. In the event that the rhythm has been ongoing for greater than 48 hours, then anticoagulation is usually instituted and transesophageal echocardiography is instituted to check for mural thrombi prior to instituting the interventions to attempt to convert the rhythm to sinus rhythm. Obviously, if the patient is symptomatic as a result of atrial flutter or atrial fibrillation, cardioversion is always an option. As a long-term therapy for atrial flutter or atrial fibrillation, radiofrequency catheter ablation usually can be instituted. This concludes our discussion on atrial arrhythmias.